Chapter 18 in TIMBY, Caring for Clients with Cancer. Understanding cancer. The cell is the basic structural unit in plants and animals. Differentiated cells work together to perform specific functions. Cell regeneration occurs through cell division and reproduction. Abnormal changes in cells develop for many reasons. These abnormal cells reproduce in the same way as normal cells, but they do not have the regulatory mechanisms to control growth. Abnormal cell growth proliferates in an uncontrolled and unrestricted way. New growths of abnormal tissue are called neoplasms, or tumors. The first part of the tumor's name indicates the particular cell or tissue. The suffix or ending "oma" indicates it is a tumor. Four main cancerous tumor classifications according to tissue type are carcinomas, cancers originating from epithelial cells; lymphomas, cancers originating from organs that fight infection; leukemias, cancers originating from organs that form blood; myelomas, cancers originating from plasma cells; and sarcomas, cancers originating from connective tissue such as bone or muscle. In Table 18.1 in TIMBY on page 257, you can see selected benign and malignant tumors by tissue type. If the tissue type is epithelial, it could be surface or glandular. Surface, the benign tumor form would be called papilloma. The malignant tumor form would be called squamous cell carcinoma. If the epithelial cells are glandular, a benign tumor would be called adenoma. A malignant tumor would be adenocarcinoma. Connective tissue, in terms of cancer, if it was a fibrous connective tissue, a benign tumor would be called fibroma. A malignant tumor would be called fibrocarcinoma. If the connective tissue was adipose, it would be called a lipoma if it was benign, and liposarcoma if it was malignant. If it was cartilage connective tissue, it would be called chondroma, and if it was malignant, it would be called chondrosarcoma. If it was cartilage connective tissue and it was benign, it would be named chondroma, and again, chondrosarcoma for the malignant form. If it was bone connective tissue, it would be called osteoma for benign and osteosarcoma for malignancy. If it was blood vessels connective tissue, it would be called hemangioma for a benign tumor and hemangiosarcoma for a malignant tumor. If it's in the lymph vessels of connective tissue, it would be called lymphangioma. If it was malignant, it would be called lymphangiosarcoma. If it was lymph tissue and malignant, it could also be called lymphosarcoma. If it was muscle tissue, smooth muscle, benign tumor would be called a leiomyoma. If it was a malignant tumor, it would be called leiomyosarcoma. If it was striated muscle, the benign form of the cancer would be rhabdomyoma. If it was malignant, it would be rhabdomyosarcoma. If it was in the neural system, a nerve cell cancer, the benign form would be neuroma. The malignant form would be neuroblastoma. If it was the glial tissue, and if you remember, the glial cells are a supportive cell in the central nervous system. They're different than neurons. Glial cells do not conduct any electrical impulses. The glial cells surround neurons and provide support and insulation between them. Glial cells are the most abundant cell types in the central nervous system. So if it's a glial cell cancer and it's benign, it's glioma. If it's malignant, it's glioblastoma. In the meninges of the neural system, it would be called meningioma if it was benign, and meningeal sarcoma if it's malignant. Hematologic cancers, you have erythrocytic tissue and basically no benign forms. The malignant form would be erythrocytic leukemia. The plasma cells have no benign form of cancer. They only have malignant, and that would be multiple myeloma. The lymphocytic tissue cells, again, no benign form. The malignancy form would be lymphocytic leukemia or lymphoma. Endothelial tissue type cells, the blood vessels would be called hemangioma if it was benign, and hemangioma sarcoma if it was malignant. If you had cancer in the lymph vessels, it would be benign. It would be called lymphangioma. If it was malignant, it would be lymphangiosarcoma. Benign tumors are non-invasive. They can grow large. They have a slow growth rate. They do not usually cause death unless they impair function of a vital organ, as opposed to malignant tumors, which are invasive. They have an uncontrolled growth. They cause alterations in cell membranes, and fluid movement in and out of the cells is disturbed, and it creates tumor-specific antigens. Benign tumors remain at their site of development. They may get large, but their growth rate, again, is slower than that of malignant. They usually do not cause cell death, as their location impairs the function of a vital organ, unless their location impairs the function of a vital organ, such as the brain. Malignant tumors have uncontrolled growth, and unless completely removed, are likely to undergo metastasis, which is spreading. Characteristics of malignant cells include alterations in the cell membrane that affect fluid movement in and out of the cell, and there are also tumor-specific antigens, which are proteins located in the cell membrane, which develop as cells become less differentiated. These antigens characterize benign and malignant cells from the same tissue type. In addition, there are genetic differences that promote cellular mutation, proliferation, and growth. Tumors grow and spread through projections that invade surrounding tissues. Cancers produce enzymes that break down proteins and promote infiltration, invasion, and penetration of surrounding tissues. Seeding of cancer cells occurs when tumors shed cells in body cavities. Metastasis is the development of a secondary tumor from the primary tumor at a distant location. It happens through lymph channels and blood vessels. Metastasis is one of cancer's most discouraging characteristics because even one malignant cell can give rise to a metastatic lesion in a distant part of the body. Metastatic tumors are treated aggressively when possible to improve quality of life and lengthen survival time. Cancer is known to spread to the lymph nodes that drain the tumor area. The sentinel node is the first lymph node to which a primary tumor drains. When a malignant tumor is removed, lymph node dissection may also be done, along with a wide excision of the tumor, to ensure that the margins surrounding the tumor are cancer-free. Carcinogenesis is the process of malignant transformation. The initiation process involves carcinogens, which are factors that contribute to the development of cancer. They alter the genetic structure of the DNA within the cells. Repeated exposure to carcinogens, they are called promotion, transfers the genetic information so that the cells begin to produce mutant cell populations. The final step involves malignant behavior called progression, in which malignant cells demonstrate an ability to invade adjacent tissues and metastasize. Cancer is the second leading cause of death in the U.S., where 1 in 2 of all men and 1 in 3 of all women will develop cancer at some point during their lives. Lung cancers account for more cancer-related deaths in both men and women than any other type of cancer. Common cancers in men include prostate, lung, and colorectal. Breast, lung, and colorectal cancers most commonly affect women. Genetics. Damage to cellular DNA causes cancer cells to develop. In many cases, the body repairs such damage. In cancer cells, the DNA remains mutated or damaged. Inherited gene mutations occur when the damaged DNA is passed to the next generation. Acquired mutations may occur at some point in a person's life and are not inherited. It is known that genes play a major role in cancer prevention or development. Defective genes are responsible for diverse cancers. Some types of leukemia, retinoblastoma, an eye tumor in children, and skin cancer are associated with genetic factors. Breast, prostate, and colorectal cancers are also associated with defective genes. The following information describes the genetic components linked to the development of cancer. Oncogenes. These are mutated forms of specific normal genes known as proto-oncogenes that control cell growth and replication. When a proto-oncogene mutates, it activates out-of-control cell growth and causes cancer. Tumor suppressor genes, these are normal genes that slow cell growth, repair DNA mistakes, and promote normal cell death. When tumor suppressor genes mutate, the functions are inactivated and cell growth becomes out of control and causes cancer. Other factors contribute to carcinogenesis and include chemical agents, environmental factors, dietary substances, viruses, lifestyle factors, and medically prescribed interventions. Contributing factors to cancer include chemical agents, tobacco and nicotine, exposure to asbestos, pesticides, and formaldehydes. The lungs, liver, and kidneys are especially involved because they do biotransformation. Anything of toxic substance gets cleaned out through the lungs and liver and kidneys, and so they're all vulnerable to carcinogenesis. Environmental exposure to sunlight, radiation, pollutants, electromagnetic fields, and nuclear power plants all can affect one's genes and also are carcinogens. Diets, food high in fat or nitrates, alcohol, and obesity all play a part. Viruses and bacteria, Kaposi sarcoma, H. pylori, predispose one to cancer. Medications, immunosuppressive drugs, hormone replacements, and anti-cancer drugs can also lead to abnormal cells leading to cancer. And if your immune system is defective and fails to recognize malignant cells, or is not stimulated to fight cancer cells, or it could be that the malignant cells survive and proliferate because of the immune system being immunocompromised, is another reason for possible cancer growth, cell growth. A client has all of the following in his health history, which would contribute most to the development of oral cancer. A. Alcohol abuse. B. Poor dental hygiene. C. Frequent bouts of tonsillitis. Or D. Chewing smokeless tobacco. It should be D. Chewing smokeless tobacco. Smokeless tobacco or snuff is a precipitating factor for oral cancer. Signs and symptoms. Cancer presents differently because it is not one disease and does not have one cause. Depending on the type of cancer, one or more organ systems may be involved, and presenting signs and symptoms may or may not be readily apparent. This factor underscores the importance of educating clients about prevention and self-examination so the cancer can be diagnosed as early as possible. The American Cancer Society states that general signs and symptoms of cancer include the following: unexplained weight loss, a loss of 10 pounds or more without an apparent cause. This is particularly significant for cancers of the pancreas, stomach, esophagus, and lungs. Fever is common with cancers, but it is particularly significant when a cancer has metastasized or as an early sign of leukemia or lymphoma. Fatigue that does not get better with rest. Fatigue worsens as cancer progresses, but it may also be an early sign of leukemia or cancers that are causing blood loss, such as colon cancer. Pain. This varies with the type of cancer. Early symptoms with bone cancers or testicular cancer. It's an early symptom. A headache that does not get better may be linked to a brain tumor. Back pain that has no other cause may be associated with colorectal or ovarian cancer. Most pain related to cancer is a sign of metastasis. Skin changes. These include changes associated with skin cancers, but also include the following: hyperpigmentation, darker looking skin; jaundice, yellowish skin and sclera; erythema, reddened skin; pruritus, itching, and excessive hair growth. Other signs may include changes in bowel habits or bladder function, sores that do not heal, leukoplakia or white patches in the mouth or on the tongue, unusual bleeding or discharge, thickening or lump in breast or other tissue, indigestion or trouble swallowing, recent change in a mole or wart, or nagging cough or hoarseness. In this acronym, you can see caution. C is changes in bowel or bladder habits. A, an unhealing sore. U, unusual bleeding. T, thickening lump. I, indigestion. O, obvious change in size of wart or mole. And N, nagging cough. Cancer prevention. Better education has improved awareness of both warning signals and factors that may influence cancer development. Public education focuses on periodic physical exams and cancer screening programs. Healthcare providers must emphasize and teach self-examination of the breast, testicles, and skin. Avoidance of factors that predispose people to cancer and early detection of cancer increases the chances of cure. Diagnostic findings. A client's history, physical exam, and diagnostic studies contribute to the diagnosis of cancer. In some cases, physical examination findings are unremarkable, but the client's history is suspect. In addition, the client is evaluated for risk factors. Many diagnostic studies are used to establish a diagnosis of cancer. The provider, using information obtained during the history and physical examination, selects tests that help to establish a diagnosis. Laboratory test. Specific cancers alter the chemical composition of blood and other body fluids. Specialized tests have been developed for tumor markers, specific proteins, antigens, hormones, genes, or enzymes that cancer cells release. Normally, tumor markers are not present in or not found in large quantities in the blood. Other lab tests may be useful in establishing a diagnosis. Abnormal values do not directly indicate a malignant process. They may help to formulate a total clinical picture. For example, a complete blood count may indicate anemia in a client with possible colon cancer. Occult blood in the stool may indicate colorectal cancer. X-ray imaging. X-rays are quick and painless and provide images of body structures. These images are produced based on the absorption of X-rays. Bones absorb the most, soft tissues much less. Air absorbs very little, and thus lungs show up black on the radiograph. For some tests, a contrast medium such as iodine or barium is used to highlight or outline or provide more detail. A barium enema is an example of a study done with contrast medium. Computed tomography, also called CT scans, use computer-controlled X-rays, providing three-dimensional cross-sectional views of tissues to determine tumor density, shape, size, volume, and location, as well as highlighting blood vessels that feed the tumor. The views are made through a computer and can be enlarged for better viewing. Contrast medium may be used to better define boundaries between organs and/or tumors. CT is useful in diagnosing many types of cancer. Magnetic resonance imaging, otherwise known as MRIs, produce detailed sectional images that uses radio frequency signals in the presence of a magnetic field to differentiate diseased tissue from healthy tissue and to study blood flow. It also helps to visualize tumors hidden by bone or other structures. Nuclear imaging. Clients ingest or receive IV radioisotopes, also known as tracers. After a specific time interval, images are taken of tissues that are affected by cancer or other diseases. The images distinguish tissues or portions of tissues that absorb more or less of the tracer. Hot spots show on an image of a tumor that has increased concentrations of the tracer, whereas cold spots can be the image of a tumor that has decreased concentration of the tracer. Examples of specific types of nuclear scans include the following. Positron emission tomography, also called PET scans. The PET scan uses computed cross-sectional images of increased concentrations of radioisotopes in malignant cells. It provides information about the biologic activity of the cells and assists in differentiating benign and malignant processes and responses to treatment. PET scans are used primarily for brain, lung, colon, liver, and pancreatic cancers. SPECT is single photon emission computed tomography. This is a newer imaging machine that incorporates PET scanning with CT scanning and contrast, allowing for better details related to increased cellular activity and thus improving the ability to locate tumors. Radioimmunoconjugates, monoclonal antibodies labeled with radioisotopes and injected intravenously, accumulate at the tumor site. Scanners may then visualize the tumor. These studies are particularly useful for colorectal, breast, ovarian, head, and neck tumors. They may also be used for lymphomas and melanomas. Ultrasounds use high-frequency sound waves to detect abnormalities of a body organ or structure. Fluoroscopy is a type of imaging used to show continuous X-ray images on a monitor. Vascular imaging uses contrast agents that are injected directly into veins and arteries to assess the vasculature of a tumor. MRI, CT, or fluoroscopy is used to tack the contrast agent. This type of imaging is particularly useful prior to surgical procedures for liver and brain cancers. Allergies to shellfish in particular do not increase the risk of reaction to intravenous contrast any more than that of other allergies. Other studies include a biopsy. Tissue samples, excised or removed from the body, are directly examined microscopically for malignant or pre-malignant process. Tissue samples may be obtained during surgery, by insertion of a biopsy needle under a local anesthesia, or by endoscopic procedures. A biopsy provides the most definitive method for diagnosing cancer. More information is provided in the surgery section of TIMBY. Frozen section. During some surgeries, when a tumor or node is removed, it is taken to the pathologist for immediate examination. The specimen is quickly frozen and then sliced into very thin pieces so that it can be examined under a microscope. Once the preliminary findings are known, the surgeon decides the type of surgery needed. Healthcare providers make the client aware of the possibilities before surgery. Endoscopy is fiber optic instruments are flexible tubes that contain optical fibers which enable light to travel in a straight line or at various angles and illuminate the area being examined. Specific body areas can be examined with gastroscopy, bronchoscopy, and colonoscopy. Tissue biopsies may be done if a malignancy is suspected. Cytology is microscopic examination of cells from various body areas may be used to diagnose malignant or pre-malignant tumors. Cells are obtained by needle aspiration, scraping, brushing, or sputum. An example of a cytologic test is the pap smear used to diagnose changes in the endometrium, cervix, and vagina. A nurse is conducting a skin assessment on a client. Which of the following is characteristic of a mole on the skin warrants further evaluation by a physician? A, brown color, B, irregular shape, C, located on the neck, or D, skin around area that's sunburned. You should answer irregular shape. Nevi, also called moles, are typically brown. An irregular shaped mole warrants further evaluation, particularly if the mole was once circular and has changed. Staging of tumors. Tumors are staged and graded based on how they tend to grow and the cell type before a client is treated for cancer. The American Joint Committee on Cancer developed a staging system referred to as the TNM classification. T indicates the size of the tumor, N stands for the involvement of regional lymph nodes, and M refers to the presence of metastasis. Once the TNM descriptions are established, they are grouped together in a simpler set of stages that include tumor size, evidence of metastasis, and lymph node involvement. Stage 0. The cancer is in situ, S-I-T-U, abbreviated CIS, which means that the malignant cells are confined to the layer of cells in which they began with no signs of metastasis. Stages 1, 2, and 3. Higher numbers indicate that the tumor is of greater size and or the spread of cancer to nearby lymph nodes and or organs near the primary tumor. Stage 4. Cancer has invaded or metastasized to other organs of the body. Grading of tumors involves the differentiation of the malignant cells. Basically, there are two classifications, differentiated and undifferentiated. Cancer cells are evaluated in comparison with normal cells. Well-differentiated cells are those that most closely resemble the tissue of origin. Undifferentiated cells bear little resemblance to the tissue of origin. Cell differentiation is graded from 1 to 4. The higher the number, the less differentiated the cell type. Tumors with poorly differentiated cells are graded 4. These tumors are very aggressive and unpredictable, and the prognosis is usually not good. Grade 4 tumors do not respond well to cancer treatments. Treatment of cancer. There are 4 primary treatment options used to treat cancer: surgery, radiation therapy, chemotherapy, and hematopoietic stem cell transplantation. Immunotherapy, gene therapy, and other alternative therapies also may be used. Cancer frequently is treated with a combination of therapies using standardized protocols. Surgery continues to be a primary method for diagnosing, staging, and treating cancer. Newer and less invasive surgical techniques allow for removal of tumors while preserving as much normal tissue and function as possible. Surgery may range from tumor excision alone to extensive excision, including removal of the tumor and nearby structures such as bone, muscle, and lymph nodes. The type and extent of surgery depends on the extent of the disease, the actual pathology, the client's age and physical condition, and anticipated results. When tumors are confined and have not invaded vital organs, the surgery is more likely to be curative and is referred to as the primary treatment. In some cases, the entire tumor cannot be removed, but as much of it as possible is removed, which is referred to as debulking or cytoreductive surgery. Two types of excisions are generally done. The first is local excision, in which the tumor is removed along with a small margin of healthy tissue. The other type is wide or radical excision, which removes the primary tumor, lymph nodes, and any involved adjacent structures and surrounding tissues that pose a risk for metastasis. Diagnostic and staging procedures are also done to obtain tissue samples used to determine cell type and the extent of the cancer. Prophylactic or preventative surgery may be done if the client is at considerable risk for cancer. Prophylactic surgery may be discussed when there is a family history or genetic predisposition, the ability to detect cancer is at an early stage, or the client is able to accept the postoperative outcome regardless of the findings. Examples of prophylactic surgery include mastectomy and hysterectomy. Clients who choose prophylactic surgery require careful preoperative counseling and teaching so that they are fully aware of the consequences of surgery. Surgery also helps to relieve uncomfortable symptoms or prolong life is considered palliative. Some palliative surgeries are used to remove excess fluid and increase comfort, such as paracentesis, which is removal of fluid from the abdominal cavity, and thoracentesis, which is removal of fluid from the chest. Surgical procedures used to relieve pain also include nerve blocks, placement of epidural catheters for administration of epidural analgesics, and placement of venous access devices for administration of parenteral analgesics. Reconstructive or plastic surgery may be done after extensive surgery to correct defects caused by the original surgery. Some surgeries are disfiguring or so profound that the client may have difficulty adjusting to body changes. In these cases, radiation therapy may be a better option. Other surgical interventions include the following. Cyrosurgery, that uses liquid nitrogen spray or a very cold probe to freeze and kill abnormal cells. Electrosurgery uses a high-frequency electric current to destroy tumor cells. Laser, which is light amplification by stimulated emission of radiation surgery, uses photoablation and photocoagulation lasers to aim light and energy directly at an exact tissue location and depth to vaporize cancer cells, destroying tissue or sealing tissues or vessels. Radiofrequency ablation uses high-energy radio waves through a needle to heat and destroy cancer cells. Mohs surgery, formerly called chemosurgery, involves shaving off one thin layer of skin at a time. Each layer is examined microscopically. Surgery ends when all cells look normal. Chemosurgery involves the use of topical chemicals as layers are removed, but is not part of Mohs surgery. Laparoscopic surgery uses a long, flexible scope through a small incision to inspect and remove pieces of tissue. This type of surgery is selectively used for some cancers. Robotic surgery is similar to laparoscopic surgery. The surgeon sits at a control table and guides precise robotic arms to pass a scope through a small incision to inspect and remove tissue. Radiation therapy uses high-energy ionizing radiation, such as expected side effects of therapy include alopecia, which is hair loss, erythema, which is local redness and inflammation of the skin, desquamation, which is shedding of epidermis, which can be dry or moist. Alterations in oral mucosa include stomatitis, which is inflammation of the mouth, xerostomia, which is dryness of the mouth, change or loss in taste and decreased salivation, anorexia, which is loss of appetite, nausea and vomiting, diarrhea, cystitis, which is inflammation of the bladder, pneumonitis, which is inflammation of the lungs, fatigue, and myelosuppression, which is depression of bone marrow function if marrow-producing sites are irradiated, resulting in anemia, which is decreased red blood cells, hemoglobin, or volume of packed red blood cells. Leukopenia is decreased white blood cell count, which can happen, and thrombocytopenia, which is decreased platelet count. Effects of radiation are cumulative. Often the client experiences chronic or long-term side effects after completing therapy. Many times these effects result from decreased blood supply and normal tissue destruction. The changes are irreversible. Possible effects include fibrosis, which is abnormal formation of scar tissue in the small intestine, lungs, and bladder, cataracts, disturbances in blood cell formation, sterility, and new cancers. Radiation safety. The National Council on Radiation Protection and Measurement publishes guides for radiation safety. The effects of long-term and short-term exposures must be considered. The latent period between the exposure and the accumulated biologic effect often is long, and great care is taken to protect occupationally exposed workers from radiation injury that can accumulate over the years. Pregnant women should avoid exposure to radioactive substances. When nurses provide information, clients need to know the type and duration of treatment, what is required of the client, possible side effects, skin and mouth care, nutritional and dietary concerns, and the precautions that are necessary. Client and family teaching provides additional teaching points in TIMBY on page 266. When radioisotopes are used to treat cancer, 3 safety principles must always be kept in mind. Time, distance, and shielding. Time refers to the length of exposure. The less time spent in the vicinity of a radioactive substance, the less radiation is received. Nurses must work quickly and efficiently to spend minimal time at the bedside. Clients are placed in private rooms. Healthcare personnel who are involved in the care of the client wear dosimeter badges. Careful psychological preparation helps the client accept the limited amount of nursing time. Visitors are limited to 30 minutes a day. Distance refers to the length in feet between the person entering the room and the radioactive source, which is the client. The inverse square law applies to radiation exposure. The rate of exposure varies inversely to the square of the distance from the source, which is the client. For example, nurses standing 4 feet from the source of radiation receive 25% of the radiation they would receive if they stood 2 feet from the source. Visitors must obtain a distance of at least 6 feet from the client. Shielding is the use of any type of material to decrease the radiation that reaches an area. The material usually used is lead, such as lead-lined gloves and lead aprons. Other materials, such as concrete walls, are capable of shielding. A client has frequent nausea and vomiting following radiation to the abdomen. An appropriate intervention for the nurse is to A. Administer antibiotics before meals, B. Monitor fluid intake and output, C. Serve the diet while food is hot, or D. Provide music and conversation during meals. The most important thing you can do is monitor fluid intake and output. Fluid imbalance could result easily from nausea and vomiting, so it's very important to monitor fluid intake and output and also result in electrolyte disturbances. Treatment. Chemotherapy uses anti-neoplastic agents that work by interfering with cellular function and reproduction. These agents may be used alone or combined with other therapies to cure cancer, prevent it from metastasizing, slow its growth, destroy tumor cells that have been metastasized, or relieve symptoms. Anti-neoplastic agents are classified according to their relationship to cell division and reproduction. Healthy and malignant cells follow a cell cycle pattern, which involves division of the cell and reproduction of 2 identical daughter cells. There are distinct phases within the cell cycle. Number 1, synthesis, S, and mitosis, M. These are the 2 major phases of the cell cycle. The S phase lasts 10 to 12 hours, involves DNA synthesis and replication of chromosomes. The M phase, remember mitosis, lasts less than an hour, includes mitotic spindle formation and cell division with the formation of 2 daughter cells. Number 2, gaps 1 and 2, which is called G1 and G2. Gaps are part of the cell cycle because cells require time to grow. and double their mass of proteins and organelles. G1 is the stage when protein synthesis and organelle and cytoskeletal elements increase to prepare for DNA replication and mitosis. G2 is the pre-mitotic phase in which enzymes and other proteins needed for cell division are synthesized and moved to the appropriate sites. Number 3, gap 0, otherwise known as GO or G0, is the stage after mitosis in which a cell can leave the cell cycle and remain inactive or re-enter the cell cycle at another time. Examples include permanent cells such as neurons are differentiated after mitosis and leave the cell cycle and never return. As such, they are incapable of cell renewal. Again, stable cells such as hepatocytes enter GO after mitosis but can re-enter the cell cycle when stimulated by the loss of other cells. 4. Checkpoints and cyclins. Most cells have checkpoints in the cell cycle that can be arrested if previous events are not complete. For example, the G1S, which is the G1 synthesis checkpoint, monitors whether there is damage to the DNA in the chromosomes caused by radiation or chemicals. The G2 mitosis checkpoint prevents entry into mitosis if DNA replication is incomplete. In addition, cyclins are proteins that control the entry and progression of cells through the cell cycle. The function occurs through activation of proteins called cyclin-dependent kinases, CDKs. Different combinations of cyclins and CDKs regulate the cyclin-CDK complexes and are most important in regulating cell cycle checkpoints for repairs of mistakes in DNA replication. Cell cycle specific drugs. Anti-neoplastic drugs are most effective during cell division. Cell cycle specific drugs are used to treat rapidly growing tumors because they attack cancer cells when they enter a specific phase of cell reproduction. Most chemotherapeutic agents affect cells in the S phase by interfering with RNA and DNA synthesis. Others are more specific to the M phase or mitosis phase. Chemotherapy is administered in multiple repeated doses to produce a greater cell kill and to halt the growth of tumor cells. Examples of cell cycle specific agents are topoisomerase 1 inhibitors, anti-metabolites, mitotic spindle poisons, and some of the miscellaneous agents. I will spell the topoisomerase. It's topoisomerase 1 inhibitor. Cell cycle nonspecific drugs are effective during any phase of the cell cycle, whether reproducing or resting. They are used for large, slow-growing tumors. The amount of drug given is more important than the frequency. Cell cycle nonspecific drugs have more prolonged effects on cells, which results in cell damage and destruction. They often are given in combination with cell-specific drugs and also may be combined with or follow radiation therapy. Examples of cell cycle nonspecific agents are alkylating agents, anti-tumor antibiotics, nitrosoureas, hormones, and some of the miscellaneous agents. Routes and devices for administration of chemotherapy. Chemotherapeutic drugs are administered by several routes. The most common are the oral and IV routes, but they also may be given via intramuscular, subcutaneous, intraperitoneal, arterial, intrapleural, topical, or intrathecal routes, or directly into a cavity. Dosage is based on the client's total body surface area, prior responses to chemotherapy and other therapies, function of the major organs, and the client's health status. IV administration is monitored closely to prevent the drug from leaking into surrounding tissues, referred to as extravasation. Inspecting the site daily for signs of thrombophlebitis, such as tenderness, pain, swelling, and induration, is also important. Most anti-neoplastic agents can be very irritating. Blistering and tissue necrosis are possible effects of extravasation. If a client complains of burning or pain during the chemotherapy infusion, the drug must be stopped. Vesicants are particularly damaging anti-neoplastics in that they cause tissue necrosis of underlying tendons, nerves, and blood vessels. Sloughing and ulceration of the skin may be so severe that the client needs skin grafts. If vesicants are being administered, there are protocols for treating the extravasation. In addition, there are safety issues for the nurse who administers chemotherapy. Various vascular devices are used to administer chemotherapy and are particularly beneficial for long-term chemotherapy. The client does not have to endure repeated venipunctures. In addition, they are beneficial when a client has poor veins. One method used is the insertion of a venous access device, which are special catheters inserted into a peripheral or central vein so that the catheter tip is located in the superior vena cava or right atrium. Examples include peripheral indwelling catheters called PICC lines, PIC, peripherally inserted central catheters, which are also called PICC lines with two C's, PICC, and external catheters named Hickman catheters or Broviac catheters. Another type is the implanted vascular device called IVAD, also referred to as a port. A metal or plastic port encloses a self-sealing silicone rubber septum. The port is surgically implanted subcutaneously just under the skin. A silicone catheter attached to the port is threaded subcutaneously to the right atrium. To access the port, a needle is inserted in the self-sealing septum of the port. Chemotherapy infusion pumps are used for some cancers. They provide constant infusion of an anti-neoplastic drug directly into the cancerous organ. A small pump, similar in size to a hockey puck, is surgically implanted subcutaneously in the abdomen or attached externally. Adverse effects of chemotherapy. Some clients experience very little discomfort or very few adverse effects. Others have a wide range of symptoms. The tissues most susceptible to chemotherapy are those with rapidly growing cells such as epithelial tissue, hair follicles, and bone marrow. Chemotherapy can potentially harm all body systems. Common adverse effects associated with chemotherapy include nausea and vomiting, especially during the first 24 hours after chemotherapy administration. Use of concurrent antiemetics helps to reduce the incidence and severity. Stomatitis and mouth soreness or ulceration may result from destruction to the epithelial layer. Alopecia develops because chemotherapy affects rapidly growing cells of the hair follicles. Myelosuppression results from inhibition of the manufacture of red and white blood cells and platelets. Severe anemia, bleeding tendencies, leukopenia, neutropenia, and thrombocytopenia are possible if bone marrow depression is really severe. Blood transfusions may be necessary as well as protection of the client from infections. Fatigue results from the aforementioned effects, the chemotherapy itself, and the increased metabolic rate that accompanies cell destruction. Anti-neoplastic drugs are potentially toxic. Nurses must be thoroughly familiar with their adverse effects and toxicity. The dose or length of treatment depends in some cases on the client's response to therapy. Nursing management of the client receiving chemotherapy varies depending on the drug, the dose, and the route used. Client teaching is an important nursing responsibility. In addition, there are recommended safety procedures that nurses must follow when caring for clients receiving chemotherapy. When managing clients receiving chemotherapy, monitor the client for symptoms of anaphylactic reaction, which is hives, itching, sensation of a lump in the throat, shortness of breath, and wheezing. Assess for electrolyte imbalances. Prevent extravasation of vesicant drugs. Implement measures to treat extravasation of vesicant medicines if it occurs. Assess for signs of bone marrow depression, decreased white and red blood cell, granulocyte, and platelet counts. Assess for signs of bleeding and infection. Monitor for signs of renal or kidney insufficiency. Check for elevated urine-specific gravity. Watch for abnormal electrolyte values. Insufficient urine output, less than 30 mils per hour. Elevated blood pressure, blood urea nitrogen, and serum creatinine. Inform the client about the reasons for the nausea and vomiting. Administer antiemetics before and during administration of chemotherapy. Assess oral mucosa for dryness, redness or swelling, lesions, ulcerations, sticky saliva, and white patches. The nurse should teach the patient to keep all appointments for chemotherapy. If hair loss is anticipated, purchase a wig, cap, or scarf. Hair usually begins to grow again within 4 to 6 months. Make the following dietary modifications. Eat small, frequent meals. Eat slowly. Eat cool, bland foods and liquids. Suck on hard candy during chemotherapy if taste alterations occur. Avoid hot or very cold liquids, food with fat and fiber, spicy foods, and caffeine. Increase fluid intake to 2,500 to 3,000 milliliters per day unless contraindicated by the physician. Report excessive fluid loss or gain, a change in the level of consciousness, increased weakness or ataxia, which is a lack of muscle coordination, paresthesia, which is numbness, prickling, or tingling, seizures, persistent headache, muscle cramps or twitching, nausea and vomiting, or diarrhea, and to have periodic evaluations and examinations as recommended. Stem cell transplantation. Cancers that are very sensitive to high doses of chemotherapy and radiation therapy may be treated with stem cell transplantation. Stem cell transplantation or hematopoietic stem cell transplantation is done to restore stem cells destroyed by disease or cancer treatments such as chemotherapy and or radiation therapy. Stem cells refer to the young, immature cells called hematopoietic or blood-forming stem cells. They are responsible for the formation of red blood cells and white blood cells and platelets. They are mostly found in the bone marrow, but are also in the bloodstream, referred to as peripheral stem cells, and in umbilical cord blood. For some types of cancer, such as leukemia, the white blood cells from the donor identify any remaining cancer cells and destroy them. In addition, the new stem cells develop into healthy blood cells, settling into bone marrow and producing new blood cells, a process referred to as engraftment. For adults, stem cells are generally obtained from bone marrow or peripheral blood. Umbilical cord blood is also a source for children but can be used for small adults as well. There are 3 types of stem cell transplants: autologous, allogenic, and synergenic. Autologous, or AUTOLOGOUS, autologous stem cell transplants are obtained or harvested from the client himself or herself, either from bone marrow or circulating blood. The stem cells are removed from other bone marrow or circulating blood. The stem cells are removed before other cancer treatments and frozen to be reinfused after cancer treatment is complete. Clients having autologous stem cell transplants do not require immunosuppressant drugs, but they can still be at risk for graft or transplant failure. There are risks. There may be tumor cells present in the stem cells, and or the client's immune system has not changed and still cannot fight off cancer cells. A process called purging may be used to remove the cancer cells with chemotherapy. Autologous stem cell transplants are used for some leukemias, lymphomas, and multiple myeloma. Research is ongoing to use this type of stem cell transplantation for other diseases, such as autoimmune disorders and other cancers. Allogenic stem cell transplantation is spelled ALLOGENEIC, uses stem cells from a donor whose tissue type matches the client's. Typically, blood relatives are tested for their potential to be the donor, but a donor may be found from a national registry. The donor can donate additional stem cells if required because they are obtained from peripheral blood. Donor stem cells produce immune cells that can destroy any remaining cancer cells, referred to as graft versus cancer effect. Engraftment may not occur with allogenic transplantation. Recipients are also prone to infections carried by the donor, although donors are carefully screened. Another risk is graft versus host disease, in which the donor cells produce new immune cells that attack the recipient's healthy cells. To prevent this, clients receive immunosuppressant drugs. Allogenic transplants are primarily used for cancers affecting blood, such as leukemia and other bone marrow disorders. A more recently developed type of allogenic transplant is called a reduced intensity transplant, or non-myeloablative transplant, or mini transplant. Clients having this type of transplant have reduced doses of chemotherapy and or radiation therapy. The donor cells are then able to assist in the destruction of tumor cells and with time replace the recipient's own bone marrow cells. This method is most effective in clients whose disease is slower growing and less extensive. Synergenic stem cell transplantation is rarely done because it is possible only if the client has an identical sibling with an identical tissue type. Synergetic stem cell transplant does not cause graft versus host disease. So this is a great advantage. However, all cancer cells must be destroyed prior to transplantation because the donor stem cells cannot destroy any remaining cancer cells. Targeted therapies include biologic response modifiers, nonspecific biologic response modifiers. Examples are cytokines, interferons, and interleukin 2. Monoclonal antibody immunotherapy is used. Also, cancer vaccines are in clinical trials right now. Hyperthermia is another application of heat to destroy cancer cells. Photodynamic therapy uses light to burn or destroy cancer cells, and gene therapy is using genetics to try to repair or come into and interfere cell reproduction with the mutant cells. Some of the nursing care plans that you can use for a patient with cancer is nursing diagnosis of fatigue. You want to encourage protein and calorie intake, plan care around their energy level. Another nursing diagnosis would be imbalanced nutrition, less than body requirements. You want to encourage intake of sufficient calories and administer antiemetics as ordered before meals. Nursing diagnosis, disturbed body image, explore their strengths and their resources and support groups. Care of the terminally ill client, gently and carefully and sensitively carry out tasks to reduce pain and discomfort, control pain, provide adequate fluid and nutrition, keep the patient warm and dry, control odors and maintain dignity, and provide emotional support. This is the end of the slideshow.